no, we can continue to the COVID class, the lecture actually.
Okay.
Very nice because we are here in the peak of the curve. So your lecture here will be very insightful for us right now. Thank you.
Okay, thank you. Yeah, so so this lecture really is derived from the work that we've done over the past couple of months. You know, I think as we all know, the pandemic hit Asia and Europe before it hit the US, and then now it's certainly hitting you guys in South America much more. And so hopefully you can learn some of these lessons that we learned and continue to work with us to develop some of these ideas. So the first thing that really I want to talk about, again, kind of going back now in a much briefer history, is why we're worried about COVID from an otolaryngologist perspective. And really a lot of this comes down to this concept of aerosolization. And so the reason that ENT as a field has been hit particularly hard, it actually goes back to 2010, which were the first studies that showed that the original SARS-CoV virus had an exposure severity, meaning higher dose exposure led to more severe disease. So in the healthcare field, particularly as groups and docs who are directly working with potential respiratory droplets and aerosols, that is of concern. So as we know, in the end of December, SARS-CoV-2 emerged in Wuhan. And then it was until mid-February that really the first article in the New England Journal came out showing that viral titers were the highest in the nose and nasopharynx. In mid-March, this was declared a pandemic by the WHO. And then only a week later, another concerning data point came out again in the New England Journal showing that virus could persist and be infective in air for at least 3 hours. This was then actually around the same time we started to hear reports of particularly high infection rates among ENTs and ophthalmologists in China. And then there was a very notorious report of a pituitary surgery that infected, a transnasal pituitary surgery that infected almost the entire OR team. Now that story has evolved over time, and it's really not clear whether that happened or to the extent that which that happened. But at the end of the day, what I would say is that it raised the concern level for us as otolaryngologists significantly. And at that time, if you looked at in the US blog posts and you know, just sort of in conversations, everybody had their own ideas of what the problem was, how to mitigate this. But really, it became clear that nobody had a good understanding of the problem itself. And that was why we sort of went in and did a deep dive into the literature to understand what was the risk specifically as it pertained to aerosols. And so aerosols are small particles that are generated by the induction of airflow over an air-liquid interface. As we do that, the particle size that comes off of that air-liquid interface is inversely proportional to the air speed. So that more air and the higher velocity, the smaller the particle size, and the smaller the particle size, the farther it goes. So larger particles don't go as far, they follow more of a ballistic curve and drop, whereas small particles can extend very far. And so when we think about particle size and transmission distance, and as it pertains to infectious transmission, there are two broad categories of transmission. We think about the direct transmission through droplets, and these are particles between, let's say, 20 to 100 microns or 30 to 100 microns that travel typically less than a meter. And that's in distinction to airborne aerosols, which are typically less than 10 microns, so smaller. And these are also called droplet nuclei that travel over a meter. So these are the ones where we worry about infecting large rooms and indoor spaces. But it's also important to understand that particle size is a spectrum. It's not one or the other. And for example, particles that are 20 microns, so somewhere in the middle, can be ejected into the air and can evaporate into a smaller particle that basically floats and becomes airborne. So really, it's a spectrum and it's a moving target. It's not just droplet or aerosol, airborne aerosol. When we think about where these aerosols come from, we can then differentiate physiologic aerosols, meaning aerosols that come from our bodies and are produced by the physiologic activity of our bodies versus aerosols that we encounter during surgical procedures. So physiologic aerosols are generated in these very small distal respiratory bronchioles in the bronchial tree. And in fact, it's found that they actually are produced during your inhalation phase, which is somewhat surprising. But as you inhale and these bronchioles dilate and pop open, that's when the aerosols come into the airway and then are exhaled into the environment. And there are some other surprising features of these aerosols physiologically. For example, normal breathing actually produces a higher concentration of aerosols than coughing, although coughing produces higher velocity aerosols. And again, that's likely related to the proportion of these respiratory bronchioles that are open during normal inhalation versus spastic coughing. The other thing to bear in mind is that coughing and sneezing produce between 1 to 500 micron particles. So basically, across that whole range of airborne to droplet-sized particles, although the majority are on the larger size of things. And so when we think about airborne transmission, which again is now in the smaller particle size, not only are we worried about these particles because they can be, basically in the airspace of a poorly ventilated space, but they also, when you inhale them, they bypass the upper airway and are deposited directly into the lungs themselves. And that actually speaks to certain pathogens that prefer airborne versus droplet transmission. And so when we think about these, there are sort of three types of transmission with respect to airborne transmission that you can talk about. The first is obligate, and these are pathogens like tuberculosis that require airborne transmission because they have to infect the distal lung. There are the preferential ones, which prefer airborne but can still use direct, and these are something like measles. And then finally, you have the opportunistic aerosols, which prefer a direct infection but can use the airborne transmission vector. And that was at least true for the SARS-CoV virus. Now, this is all sort of speaking generally. There's also this concept of the aerosol generating procedure, which we've all heard a lot about now. And these are essentially procedures that create conditions favorable for this opportunistic transmission and typically occur in the healthcare setting when you're manipulating or instrumenting the airway, and in particular, in many cases, putting air into the airway, such as during intubation and so forth, that can then basically create more airborne aerosols than would otherwise be created physiologically. And so when we think about the risk of aerosolization, and particularly in COVID, again, there's really, what we discovered is that nobody had ever really looked at this in the ENT literature. And that was surprising. And I think it's opened our eyes not only to risks related to COVID, but more generally the types of procedures that we do and what we're exposing ourselves to as practitioners. But this paper came out on April 3rd, which has now been highly cited and talked about, which is really looking at the aerosolization risk of, in this case, primarily droplets, although then we followed this up looking at airborne risk as well. And so what we did here was we used a cadaveric model with this grid, and we simulated droplet spread with things like sneezing using an atomizer that was placed through a cribiform defect and then sprayed out the nose. And what we did was we used fluorescein labeled droplets, and we used a blue light filter to quantify both the size and the distribution of these droplets. And then we also wanted to look at various mitigation strategies, and this was where we came up with this concept of the vent mask. And so the vent mask was really an idea that I know now you guys have a nice video that Dr. Miyake put together of using common clinic-based materials in order to help protect ourselves as we did diagnostic procedures. And so in this case, what you do is you cut out the finger of a non-latex glove and you sort of extend this into the palm. You drape it over the front and back of a surgical or procedural mask, and you put 4 staples in, so you create a sort of a seal around it. And then just by cutting a slit through all 3 layers, now the glove, mask, and glove, you can pass a scope through while it's relatively adherent, so that it's more or less watertight as you do a diagnostic endoscopy. And so we looked at these various conditions as it would pertain to what we would consider an outpatient condition if a patient had a simulated sneeze. And what we found was that if you did not wear a mask, or if you just put a hole in the mask, you got significant spread of these droplets up to, somewhere between 60 to 70 centimeters away from the patient's nostril. But when we used a surgical mask or a vent mask, then you're able to mitigate that pretty significantly. Now, again, these are droplet-sized particles. And this is just a semi-quantitative view showing the distribution of these particles in gray here without a mask, and then with a mask with a hole in it. But again, the vent mask condition, the surgical mask condition did a nice job of preventing droplet particle spread. But we then wanted to take it a step further. And so we did a follow-up study, which was published in the White Journal now last month, And we looked at airborne particles less than 10 microns. And so we first looked at various conditions and this case was not in a cadaver, this was in a live volunteer. That's the other big difference. And so what we found was that when you perform nasal endoscopy or have speech that's not protected by a source control, you actually do get detectable airborne particles, which is concerning because, again, you're in an enclosed room and very close to the patient, although sneezing did produce much more particles in order of magnitude higher. When a patient coughed, or in this case, the volunteer coughed or had heavy breathing, we didn't see as many particles. In fact, it wasn't statistically significant, but we certainly saw some over background. Now, taking the sneeze condition, we looked at various ways to mitigate that. And what we found was that it was really only the N95 respirator with or without the vent modification that dropped the particles down to essentially undetectable. Unfortunately, the surgical mask, which works well for droplets, doesn't work well for airborne particles. And those are the more concerning particles, which is why if a patient is sneezing or you're inducing sneezing during procedures, that's why you still need to wear high-level PPE. Now, again, if you sneeze with no mask condition, you have a significant particle release. And then we also wanted to look at how many particles are produced by our common topical anesthetic nebulizers and decongestants. And unfortunately, those are extremely high. And so that's why we've gone away from using those types of anesthetics in our outpatient clinics. Now, unfortunately, as you may gather, if you're not using topical sprays, then your chance of sneezing goes up. And so you have this sort of vicious cycle here, which is concerning. Now, the issues around surgery are very different. And the reason for that is, as I mentioned, the physiologic aerosols are produced in the lower airway. But as we know, in most of our patients under general anesthesia, they have an endotracheal tube in with a cuff up, which means we're actually excluding the lower airway. But we know that aerosols are produced by high velocities over air-liquid interfaces. And so now, really the aerosols that we're concerned with are ones that are generated by the instruments themselves and not the patient. And so again, since the lower airway is occluded, that's sort of the difference. And again, the ENT literature really didn't have a whole lot, although the orthopedic literature actually has looked at this in the past. And so we can divide surgical procedures into thermal procedures, which also produce aerosols, but do it through carbonization, versus cold instrumental aerosols that do it through speed. Now, if we look at the thermal procedures, it's actually already been shown, and we know that electric cautery produces extremely small ultrafine particles, and we know that you can detect viral DNA in the plumes of cautery and laser. On the other hand, when we look at cold powered instrumentation like drills, the orthopedic literature teaches us that when you use the drill, you can contaminate the whole OR with things like Staph aureus. You can contaminate the surgeon. So this is a paper where they used, again, a UV light and fluorescein or fluorescent labeled particles. And then also you can detect, historically, it's been shown you can detect active HIV virus in these aerosols coming off drill bits. So again, we said, okay, well, we certainly use drills in many of our skull-based procedures. We certainly use cautery. So we wanted to think about what the risk was in our population. And so here we use the same cadaver setup, and we looked at a variety of approaches, including the use of a microdebrider and drill, and then cold hand instrumentation. And so when we looked at the droplet side of things in the original paper, fortunately, we did not see any droplet production during cold instrumentation, so hand-actuated instruments like a through-cut or a Blakesley, but also even the microdebrider, we did not see any droplets produced. However, under all the drill conditions, we did see significant droplet contamination outside of the patient. We then followed that up with, again, the same airborne particulate setup, now down in the less than 10 micron particles. And what we saw was something pretty similar, which was that the suction and the microdebrider and the cold instrumentation did not produce statistically significant aerosols, but all the drill conditions, so this was a low speed drill with suction, this was a diamond drill, and this was a cutter drill, all of them produced, you can see 10 to the third to 10 to the fifth aerosols within 30 seconds. So significant aerosol risk. And then cautery was somewhere in between, just under the cutting drill. And then when we look at the distribution of the size of the particles, what we can see is that if we look at all the drill conditions, the size distribution from 1 micron to 10 microns was not very different. But when we looked at the cautery, you can see down here that really shifts down to the ultrafine particulate range, which is again consistent with the literature and just sort of validates our experimental setup. When we look here, what we wanted to do is take that low speed drill and look at particulate generation with or without the suction on. And what we found was that at least over the first 2 minutes, the suction did do a very good job of mitigating particulate generation. And so what we see is that these particles are small. They tend to float in air columns. And so generating airflow that can remove those particulates is a relatively effective way of eliminating those. And so there's a variety of sort of strategies that we're looking at to try to do that. So in conclusion, when we divide between the clinic and the operating room, the detectable aerosols in the clinic are produced during endoscopy, either flexible or rigid, during speech, and certainly sneeze is the highest risk because it produces the highest concentration of aerosols at the highest velocity and is inherently unpredictable. And again, just the application of topical anesthesia or the lack of ability to do that makes this even less predictable. So for example, yesterday I had my first sort of half day of clinic back since March. And you don't really pay attention to this usually, but out of 20 patients, about 3 or 4 of them sneezed during my procedure. So, you start to realize this is something that happens with a fairly high frequency in rhinologic patients. Now in the operating room, we found, and this really validated our original study, that essentially drilling is the biggest risk issue in addition to cautery. And so these are the types of procedures that we want to really think hard about. We want to reduce as much as possible, and we want to use as much PPE as possible. So when we think about this concept of the quote unquote aerosol generating procedure, there's a couple of issues with that. So the first is that if we look at CDC definitions, there are multiple definitions on the CDC website that in some respects compete with one another. But one of the definitions is a commonly performed medical procedure that creates uncontrolled respiratory secretion. But again, in the same website, they also say that there's not enough consensus or reporting data to create a definitive list. And so really, the concept of an aerosol generating procedure, first of all, really needs to be defined by specialty and by procedure, but also is really a policy decision more so than a definition that has practical issues. Because from a practical perspective, I would ask the question, not is this an aerosol generating procedure, but does this procedure generate aerosols that put me at risk? And those may be different, actually. A procedure that we know generates aerosols may, for a policy reason, not fall under a list as a quote unquote aerosol generating procedure. So I don't want to get lost in that that distinction, but I think there may be some policy changes that you guys have to pay attention to in your own country and your own cities that may or may not have people telling you can or can't have PPE based on that. So it's an important distinction that you want to pay really close attention to. The other thing I want to call your attention to, and this probably is the slide that has evolved and changed the most during the course of these talks that I've been giving, is whether or not in the community, COVID is transmitted by airborne aerosols. Now, initially, it was actually if you look at the WHO and the CDC, initially they said there was no human-to-human transmission. Then they said there was droplet and contact transmission. Then they said, well, maybe contact transmission isn't as prominent. But really, I think the factor that we're all looking at very closely is this sort of growing tsunami of papers that are reporting airborne transmission in the community. So not even in the healthcare setting. And so this is just an example of where that risk comes from. And also as it pertains to some of the common behaviors like speech. So for example, we know that speech does generate more aerosols than cough. We know that speech has been a significant transmitter of influenza. This issue of high infection rates among ENTs actually also extend to ophthalmologists, which in my opinion is because ophthalmologists is another specialty that operates very close to the patient's face if they're speaking in the ophthalmologist's face but are asymptomatic and not protected. There are now epidemiologic studies that have come out showing outbreaks, for example, in a restaurant in subjects up to 15 feet away from the source of the infection. Now, in this case, this was in an air conditioning airstream, but there have now been many reports of choir practices where people are singing together for prolonged periods of time in enclosed spaces where infection has transmitted in these so-called super spreader events. the most, I think, well characterized is in the US in the Skagit Valley Choir, where 45 out of the 60 participants became infected and 2 died after a 2.5-hour indoor practice session, where they had already known about the pandemic and so were distinctly not in contact with one another. And so we started to see that just this act of projecting your voice with those associated aerosols can spread throughout a large indoor space. And other choir-related outbreaks have been reported in other countries as well. And then also experimentally in journals like Science and Nature and New England Journal and PNAS, there are reports of how speech is generating thousands of aerosols that do hang in the air. They correlate with loudness. And then even as for us specifically as ENTs, we've shown that if you were wearing a mask and you're talking and the patient is talking into that mask, and then you say, okay, we'll take that mask down for an exam, just that act can release aerosols into the room. And so that's what, what we call doffing of the mask. And so that again is concerning for those of us who are performing examinations of the nose and mouth. And now there have been prominent scientists who are starting to report, at least their opinion that aerosols are significant risk factors. So at the end of the day, what I would say is that any one of these papers or opinion pieces in and of themselves is not evidence, or at least it's a small bit of evidence, but you can start to see that there is a confluence of evidence really evolving around this concept that airborne transmission is a risk factor in this disease. And my prediction is that this will become more and more prominent as the months go on. And so then the question becomes, so knowing all this data, how do we best protect ourselves and our patients? And so this really comes down to a couple of key concepts. The first is the concept of source control. And so that's basically controlling the infection from relieving the patient, and that is best done through barrier methods like masks to retain respiratory secretions. Now, as I've shown you, that's pretty good at retaining droplets, but not so good at containing airborne, which can be produced during sneezes. There are engineering controls which are designed to protect the healthcare workers from the source. Now, that actually can be a mask as well, because the mask, from the patient perspective, is source control, and from the provider perspective is engineering control. But other aspects of engineering control are things like physical barriers and air handling systems. There's environmental control, which is essentially cleaning the surfaces and decontaminating high-touch areas within your clinic, removing a lot of the sort of clutter that we're used to having in our ENT spaces, so there's less to clean as far as surfaces go. And then finally, there's this concept of universal standard precautions, and that's the assumption that every person is potentially infected or colonized with a pathogen, in this case COVID, that could be transmitted. And this is really the posture that we've adopted in our clinic, because even though we can test patients, although practically it's very difficult to test every patient that's coming to our clinic, we don't know how accurate those tests are. We don't know what the false negative rates are. We don't know what the negative predictive value is. And actually, we have a paper coming out in IFAR that raises concern that rhinologic patients specifically have a higher risk of false negative nasopharyngeal swabs because of a variety of factors related to their rhinologic disease than your average patient. So the false negative rates in the rhinologic population may be even higher than in the average patient population. And so, so the other thing to remember is that it's not just about air, that when we're talking about aerosols, we have to treat the air as a contaminant. And the two ways to do that is filtration and air exchange. With respect to filtration, it's interesting that that air filters, really what they do is and this is also true for N95 masks, the way that they treat air is through really a particle size dependent mechanism. So large particles will be basically intercepted by the various fibers of the filter, so they directly hit it. Smaller particles will go around the fibers, but because of their inertia will be drawn into the fiber and adhere to that. And then really, really small particles, because they're just diffusing and they're bouncing around just because of their thermal energy, it's something called Brownian motion, will tend to impact the fibers. But that's why actually there's not a linear relationship between particle size and efficiency of filtration. It's really these mid-range particles that have the highest risk of passing through, because they're not small enough to diffuse, but they're big enough that they don't impact. And that's why when you think about N95 masks, the the issue is that the 0.3 micron particles are the ones that most efficiently pass through. And then finally, when we think about air exchange, one of the issues there is that it's also not linear. So when we think about the number of times the air is exchanged in a particular room, that tells you how efficiently you can clear a pathogen out. So for example, if you have 6 air exchanges, which is common for US clinic spaces, for example, it takes 46 minutes before enough air exchanges have occurred to clear the air with 99% efficiency. However, it takes 69 minutes to clear the air to get an extra 0.9%. So it's not linear. This also assumes, these air exchange rates also assume that air exchange is happening in a perfectly mixed environment with no additional aerosols being added. So it's a very derived and more experimental type of number, but it's really the best that we have. So for example, in our clinic, because we have 6 air exchanges per hour, any endoscopy or procedure that we do, we close the door for an hour before we let the next patient come in. And so finally, in conclusion, when we think about the clinic space, I think the way that I think about it is the 3 Ps. The first is the patient. So we have to protect the patient from releasing particles into the environment, but also we have to protect the patient from us, right? Because we don't necessarily know that we may be asymptomatically infected on any given day, or our staff may be asymptomatically infected. So we have to protect the patient from us and us from the patient. And then same goes for the providers. Now we certainly have to protect ourselves as we do these exams that can trigger cough and sneeze and heavy breathing and so forth. But by the same token, we have to make sure that we are protecting the patient. And then finally, we have to protect what I call the physical plant. And that takes into account this concept of the surfaces and the air. So the surfaces have to be cleaned with routine EPA, at least in the US, EPA designated disinfectants. But then the air has to be controlled through appropriate air handling. And so really where the idealized control is at this nexus of all 3 of these issues. Is we want to get ourselves back to a situation where we're assuming everybody's infected, the patient and us, but all 3 of these Ps can be adequately protected simultaneously. And those are the types of things that we need in order for us to get really back to seeing patients on a regular basis. So I'll end there, and certainly happy to take any questions.
Thank you very much, Dr. Bleier. It's a pleasure having you here again. I have a personal question. So what are your recommendations for us to start? And when we start, what should we use on the office? What should we give to patients to use? So what are your actual settings on Sinus Center at Mass Eye here?
Yeah, so when to start seeing patients back, I think that has a lot to do with your local prevalence, and you want to make sure your prevalence is decreasing, and that's really a policy decision. And that's something that has to be really discussed by your own health departments. But assuming you're allowed to go back, what I would say is that the patients all need to have source control, so they need to have a procedural mask when they come in. You, as the provider, I think, in the absence of perfect knowledge of who's infected and who isn't, should be wearing high-level PPE for all procedures and examinations that involve potential aerosols. So all endoscopies, certainly, rigid or flexible. And that includes an N95 or equivalent goggles or eye protection, gowns, and gloves. And then the last thing is the room itself. If you know what your air exchange rate is, then you should titrate your rooms to that number. And then finally, with respect to sort of just patient flow and management, you in the waiting room and in the rooms, you want to maintain social distancing, and you want to have what we would call unidirectional flow if you can, which means you don't want patients walking past each other as part of your day. And so fortunately for our clinic, for example, we have 2 doors, and so we have patients come in one door and exit another door. And we've really offloaded a lot of the things we used to do, a lot of the talking and counseling and that sort of thing, to telemedicine, so that we do a lot of that care both before the patient comes in and then after by phone. So really, when they come in, they're coming in mostly for the procedure and then leaving. So it reduces the time, it reduces the turnover, and it keeps everybody safe. I would say, and this was part of my disclosures, that we are working on source control solutions that I think will make things even safer for everybody. But those are, we're still working on that.
So a lot of patients ask me this one. So I would like to ask you. So obviously the problem for us is the office setting. But for patients, for us as well, we got elevators. Elevators don't got filters, don't change air. And as you shown on your data, there's droplets and aerosol being produced all over and during speech or even breathing. So how can we protect patients during, from taking elevators? Ask them to get the stairs or?
Right. Well, I think, so the other thing that I didn't mention is this pre-screening. So, symptom screening is important. Making sure that they don't have obvious active symptoms. And then the role of testing, I still advocate for testing whenever possible, but I would just say, take a negative result with a grain of salt. But to speak to your point, if a patient is totally asymptomatic and they're not actively sneezing and coughing and hacking, and they're wearing a face mask, then the chance of them spreading the disease is very low. And so that is what allows an asymptomatic patient to be in the room with you or the room with other patients with social distancing, with minimizing the risk of transmission. So from respect to the elevators, so here you have a group of patients who ideally are not symptomatic, are wearing masks, and then you limit the number of patients per elevator to try to maximize distance. So certainly there are some things you just can't mitigate, but you can, and sort of the analogy I use with respect to sort of overlapping different things is like when we operate, what do? Well, we scrub in, then we put undergloves on, then we put overgloves on. So we have 3 different layers. So if our overglove gets a hole and our underglove gets a hole, we still have a sterile hand under there, right? So in this case, we're trying to just overlap layers to continue to drop that risk as low as we can. But on the other hand, we have to see these, our patients. We know that there's not just in ENT, but in all medical specialties, there's a harm to patients delaying care for any number of things. And so we have to balance those two. But I think those are really the best and evidence-based ways to do that.
So Marcel is here. He asked about use of N95 fan masks on patients. Are you guys using in all patients or just in patients with a high risk of having COVID?
The N95 vents? We actually aren't using them at all. And the reason is we can barely get them for ourselves, which I'm sure is the same for you guys. So unfortunately, that data is theoretical in the sense what it tells us is there are ways to mitigate source control, but that doesn't mean we can practically do it. So unfortunately, just like you guys, I'm sure, we don't have that option. Now, what would be the difference? Well, what I would say is that if we had that type of source control for every patient, we wouldn't need to rest the room in between patients. And potentially we could even reduce the PPE that we have to wear, because as I'm sure everyone has now experienced, wearing an N95 for 12 hours a day is actually very difficult. So if we can move that those source and engineering controls from the provider to the patient, that's really, remember I talked about that idealized control. Then you're controlling the air, you're potentially controlling the surfaces, and you're controlling both engineering and source control back and forth. So that's what we want to do, and that's a lot of what we're developing, hopefully to have in the future.
So another question is about exercise on the gym. So do you think, obviously it would generate a lot of droplets and a lot of aerosol. So it would increase. So that's why gyms and restaurants will be closed for a long time, right?
Yeah, I think gyms are a high risk, not just that, but also because of contact and so forth. So, in the US, you see gyms are opening. I personally am not going to any gym in the near future, but that's up to every individual.
I saw a paper on from Netherlands that saw aerosol through running. So that we should keep at least 20 meters after a person if you were running. Have you ever talked about or seen or read about?
Yeah, so so again, there's lots of different ways people have studied aerosols. There are models where they're these sort of computer fluid dynamic models. There are lab-based experimental models. There are clinic-based models like the ones we've done, and then there are epidemiologic studies. So and all of those are sort of exist in a gradation of quality of evidence, where really epidemiologic data is the gold standard. So I think, again, none of those in and of themselves are really put the nail in the coffin and say this is this is spread this way. But what I would say is that they accumulate a body of evidence that at least for me is all pointing in the same direction, which is that this is a risk factor. Now, there are other mitigating aspects of that, because there's also, again, as we talked about, a dose response, right? So you might be exposed through a cloud of aerosols, but in a highly ventilated space like outdoors, that dose may be so low that it's not an infective dose. So, I think we have to balance that as well, which is that, that it's kind of like a pharmacokinetic analysis where you think about area under the curve, which is basically you need enough of a dose to become infected. And the ways to get that is either duration of exposure or concentration of exposure or some combination of those.
All right. Makoto, do you have a question?
Just one. Professor Bleier, do you think that the aerosolization caused by surgical instrumentation is enough to cause infection?
Yeah, it's a really good question, and the answer is we don't know, because none of these studies that we've done have, and even I think, as to my knowledge, the orthopedic studies have looked at the infectivity of those viruses. In fact, very few studies at all have looked at that. So there's two aspects of the aerosol that would answer those questions. One is infectivity and one is replicativity. So infectivity means that the virus can get into a cell, but is it intact enough to then have an intact genome that it can replicate in that cell? And we don't know the answer to any of those. And I think this is sort of the same response to many of these questions, generally we know less than we want to. So then the question is, well, the data that we do know, how do we utilize that? Do we take an approach where we are maximally conservative because we know the risk is there, but we don't know the degree of risk? Or do we say, well, we know the risk is there, but we don't have data to show how effective it is, so we take a lower approach? Basically the idea here is that the absence of data is not evidence of a lack of effect. And so from my perspective, and you'll hear different opinions on this, is that if we know that these procedures are not exonerated, meaning we know they produce aerosols, then I think you have to assume at some level, at some risk factor, they're going to cause infection, particularly in surgery where you have prolonged exposure and you have many, the highest number of aerosols produced. So that's why I still am wearing, even in a patient that tests negative, I am wearing an N95 during these procedures.
Nice, thanks.
Yeah.
Anyone have questions? Well, in Portuguese or English? Questions about orbit work and anything? So that's it. I think that's it. That's a wrap up. Thank you very much, Dr. Bleier, for participating in our meeting. It's a pleasure having you here, and your work is great. Thank you very much again.
Thank you. It's been a pleasure. It's been an honor to join you guys. Thanks so much.
Thank you so much. Bye-bye.
Thanks a lot, Professor.